I think I put here challenges are what make life interesting, and overcoming them is what makes life meaningful. And I think actually donor-specific antibodies is one of these areas where I go frequently to international meetings and people stand up, like myself, as if they're an authority. And when you say to them, show me the evidence, show me this randomized controlled trial. And in fact, we've just got funding for one to happen in children and adults, which is called Target. So to kind of set this scene, and before your eyes it's moving from side to side, you can see that there's a seesaw, and isn't it amazing I can do it with the screens as well? The power I have, if I just put my hand there, it moves there. So basically we spend our life trying to deal with the battles of giving immunosuppression, and if we give too much immunosuppression, then we get infectious complications, and if we don't give enough, then we see the rejection complications coming in. So to me, the questions are, how important are donor-specific antibodies? Well, the first thing is we're all detecting them, and we're all detecting them more frequently. And part of that is because we're measuring them. And we're measuring them more frequently, and the laboratories are getting better at detecting them. So therefore, we're getting more and more data that I'm sure historically we didn't know. And in fact, I recently spoke to a colleague in another pediatric centre in the UK where they don't measure donor-specific antibodies because the adult program doesn't. They will only do it when they're doing a biopsy for renal allograft dysfunction. Gosh, their life must be a lot easier. But the problem is that the presence of donor-specific antibodies does not actually tell you what's going in the kidney, and that's why I was saying that you really need to do a biopsy. So yes, it's nice to have all those markers, and I'll show you some evidence why if you look at the natural history of antibodies. But many patients will have donor-specific antibodies for years, and they will never develop antibody-mediated rejection, which is why I say that we need a good biomarker. And we do know that some donor-specific antibodies will actually disappear. But one of the things I was going to show you is that chronic antibody-mediated rejection is actually the leading cause of long-term renal allograft failure. So nobody actually really knows, if they're going to be honest, what we should do in 2018. So we've seen these graphs before, looking at kind of long-term renal allograft survival that we've discussed. And one of the best papers that came out from the Halloran group, Solaris et al. In AJT in 2012, showed that the biggest longer-term cause of late allograft loss was actually antibody-mediated rejection. And actually, if you look at it, specifically for the group, one of the biggest areas is actually non-adherence. So I think actually when we talk about everything that we do, and we try to do, we should always remember that psychosocial assessment that you heard at the start is probably the most important aspect of long-term outcomes, and it's the young adolescents taking their medications. So it's over a decade before Colvin published this, and what he was trying to show is that one of the first things that perhaps you could modulate was finding the presence of donor-specific antibodies in the peripheral circulation. And getting that, first of all, would actually potentially be something you could modulate, because once you've got them, there is the chance that you go into the next phase where you start getting C4D deposition in the graft. And many of you will remember the original Lancet paper showed that there was a 50% prediction. In other words, having C4D positivity in the graft, whether that was going to make the graft last less long, you couldn't actually predict better than tossing a coin. But the C4D probably happens in cases before you start getting the histopathological abnormalities, and very often that will happen even before you detect abnormalities in the plasma creatinine. So we all know about HLA antibodies. You can measure them. There are fluctuating levels which happen over time, and single antigen beads are usually checked in most centers with Luminex platform. So I thought I'd just pose a question, which is very similar to the case we just saw. So a 14-year-old girl, she's got stage 5 chronic kidney disease. She has congenital anomalies of the kidney and urinary tract with bilateral renal dysplasia. 3 years ago, she had a living-related transplant from her mother, mismatch 110. She used the TWIST protocol, so as I described earlier, basiliximab. She now has come off her steroids. The basiliximab is no longer having an effect. She's just on MMF. The doses are 250 milligrams twice a day on MMF, and tacrolimus 4 milligrams twice a day, and her TAT level is 5. You're very happy how she's doing no acute rejection. You've reduced the MMF because she had EBV viremia, and you've now got a situation where you've got a DQ antibody which has come up with an MFI of 2,680. So what are you going to do? So hands up who's just going to monitor the HLA antibodies but do nothing else. So the EBV viremia, so I said she was recipient negative, EBV positive. So what happened is the EBV count went up to kind of log 3 and 4. The MMF was reduced, and it's now stabilized at about a log of 3. So again, different labs use slightly different. So there's still evidence of EBV viremia. Who's just going to monitor the HLA antibodies? Yeah, majority of people. Anybody going to shout out how often you're going to check them? Every once in a while, yes. So the British Transplantation Society asked you to measure them routinely. I go to the toilet routinely. I'm sure that's not what they meant when they said routinely. How many of you would go and straight do a percutaneous renal transplant biopsy based on that evidence? Okay. How many of you would increase your immunosuppression knowing that there's an antibody there? No? And how many don't know because you wouldn't be measuring the HLA antibodies in the first place? Okay, so maybe a couple there. So, yes?
Have you measured the area under the curve?
So we've done trough levels, partially because of the difficulty in bringing patients in. And I have to say, they tend only to be helpful when they're very high. Do you measure the AUC? Because I know a lot of units do.
Which is quite helpful in
It's,
some
yeah.
cases, because then you have an idea of what level you are.
Yep.
And you are only immune suppressive.
So if I ask the question, her creatinine was 80 and it's now 100, who would do a biopsy now? Yeah. So I think everybody's saying that despite what we've just talked about, because we don't know what to do, you're not going to stick a needle in. And in fact, some people do actually stick needles in kidneys because they want to know what it looks like. So I'm just going to touch on some of the data that we published where historically what I did is I said, why don't we go back and every single time a patient comes, we set up a protocol, we're going to test for HLA antibodies, and we're not going to do anything about it. So this was back in 2007, I think we started this, so over a decade. So in fact, this was a natural history study. So I wasn't changing immunosuppression based on HLA antibodies. So there was no minimum threshold for positivity, because that's the other debate. What's a positive MFI? Any offers? What do your labs say is positive? 250, 500, 600, 1,000? So nobody knows. So again, each laboratory's got their own way of measuring it, will tell you what they feel. And we didn't do any changes to immunosuppression. We tried to correlate that with the longer term outcomes. So we had 215 renal transplant recipients. We detected them really for at least 1 year of follow-up, but the median was 3 years. And you saw the numbers, there was about 5% retransplant, and none of them had pre-transplant donor-specific antibodies, and we excluded, obviously, HLA and ABO-incompatible transplants. And what you can see here is that the majority had some HLA antibodies, the majority of which were donor-specific, but we saw quite a few with non-specific HLA antibodies as well being present. And this was on at least 2 occasions, so we had it verified by 2 different methodologies in the lab. And what you can see here, the biggest one, as I described, was actually HLA-DQ antibody. And we don't actually currently do the matching based on looking at the DQ antibodies. So we then looked at which ones resolved. And actually, if you look at it, you were more, and in the total numbers you can see, it was the class 2 antibodies that we found that. And this basically shows what happened over time with the patients. So in other words, the longer after the transplant that you developed your HLA antibodies were more likely that they were going to persist. But actually, when you had them in your own chronological age, there wasn't really any difference between. So in other words, some people felt that the children have a developing immune system, so maybe it's different if you detect them when you're 3 compared to when you're 15. But what we found is the ones that had the highest MFI at the first detection and the ones with the highest peak MFI, usually which was around about 5,000, were the ones that were more likely going to have persistent donor-specific antibodies. So in other words, they would be permanent, they wouldn't go away. And this basically just shows some of the data looking at interquartile ranges. But then the question is what happened to these patients in the long term? And what you can see here is that those with positive DSAs actually had worse renal allograft outcomes. Their kidneys did not last as long. And that was looking at a 50% reduction in the GFR because we had quite a few patients who were not dialyzed, who weren't retransplanted, but who had GFRs which were between 15 and 20, but had previously improved. We don't have time to show you all the data, but the second paper we did was looking at those that had complement fixing antibodies. And I guess for me, there is a little bit about the complement fixation, and there are a few tests which are now available which you can then do. So when we looked at those, you can see that those who had the HLA antibodies, that were positive, had worse outcomes, and it tended to be those that had persistence of the antibodies. And we basically did various statistical analysis with it, and we did some linear modeling. And basically what we did with the linear modeling is we looked at 3 different time points of all of the patients. And again, we looked at to see what were the most likely factors. Sorry, I think the screens are going a bit ballistic again. What are the most specific factors? And in summary, the donor-specific antibodies were detected even in those patients that we classed as being low risk. So in other words, it's very difficult to predict. So if you don't measure HLA antibodies, you're not going to be able to detect them. But they can resolve in the patients who have the earlier detection and those with lower MFI, and it was associated with worse renal allograft outcome, especially in those with HLA class 2 antibodies. So I think that prevention is obviously better than cure. I think that's really what we've got to do. And I think, to be honest, we've published over the years some papers where we had minimization of immunosuppression. So we had patients who we'd kept on very low tacrolimus levels, who'd come off prednisolone because of Perthes disease, or we were worried about their height and their growth velocity. We've got then patients who came off azathioprine and mycophenolate mofetil as the antiproliferative agent, and we did that because we were worried about EBV viremia. And it's those patients that we then saw were the ones who developed the donor-specific antibodies. So you asked the question, what can you do? Well, one of the things to do is to think about how are you going to look at your immunosuppression. So as Nizam said, we have a tendency to increase our immunosuppression to try and reduce the antibodies and look at this serially and see what the response is. Obviously, antibody removal, where you will remove the preformed antibody, but you've got to stop the ongoing production. And that's why many people give intravenous immunoglobulin to modulate the immune response. But you can give, as you said, intravenous eculizumab, rituximab, and there's even bortezomib, which basically has been used in some centers and is not licensed in children and is not useful in patients, many of whom we have that are who are EBV naive, who have a positive EBV donor and therefore likely to seroconvert and run into problems. So I think in an ideal world, every child should receive a perfectly matched transplant, immunologically low risk, ABO compatible, HLA compatible, but we're now dealing in a world where we're actually detecting more of these antibodies, and therefore I think what we need to know is what is the baseline immunosuppression that each individual patient requires for the next 10 and 20 years. And I think modulating that and understanding what happens within a renal allograft is very important. And I have to say that part of it is actually dealing with non-adherence, because I think that what happens is you measure your AUC of your MMF beautifully because you tell them that you were going to come and do it, whereas it's the patients who actually don't take their medications, and some of them know exactly how to get higher levels when they come to see us in laboratory. So I kind of said, don't worry, be happy, because you're coming to the end and coming to dinner. But this is what happens. This is one young adolescent who didn't take his immunosuppression. He came in with a grade 3 vascular rejection with significant endotheliitis, significant inflammatory infiltrate, which is very, very difficult to reverse. But yet some patients seem to get by. And this is one young adult who held the flame torch at the Olympics, who went to adults on one immunosuppression agent with a creatinine of 80 and aged 18, 16 years after his transplant. Thank you very much.